Hey, Viva Lifers, this is Dr. Kelly Omdi. So glad that you're with us tonight. We are going to be talking about contraception options. And I know a lot of people, especially my peer group, are like, well, I'm done with contraception. But let me tell you, until you stop menstruating for a year and even sometimes afterwards, you actually can get pregnant. So for my people that are at the beginning of their reproductive years, those in the middle, or those towards the end, you have to prevent pregnancy in order to not get pregnant. And I know people are like, well, I've, not been using contraception of some sort, shape, fashion, way for many years, and I've never been able to, and I've never gotten pregnant. Well, I would call yourself a very low percentage. However, most women have to prevent pregnancy so that they don't do what? Get pregnant. So we're going to go ahead and get started. And one of the things I always say that is really important for us to know is our female and male anatomy. So starting with our female anatomy and the external structures, and you might ask yourself, why is this important? Well, it's important because you have to know what your anatomy looks like in order to figure out the ways to prevent pregnancy. Some people, when we talk about sexual activity, some people are not aware that sexual activity can be oral, vaginal, anal, and some people don't even know what their body parts look like that can actually cause them to be receptive of sperm, semen, in order to get pregnant. So that's why we're going over it. So as you can see at the top, the mons pubis, so that is really kind of that mound just below your pubic bone, the kind of the swelling of skin right above the top of your clitoris. You can see right there where it sits clitoris, as well as the labia minora, which are the small lips, the labia majora, which are the large lips, and then the anus, which is the rectum, or where your stool comes out of. Your urethral orifice is where your urine comes out of, and the hole in the middle is the vagina. So if you place a penis that has semen into the vagina, or you have semen that is around the vaginal opening and the semen swims, then you can get pregnant. So when people are saying, oh, we don't really have sex, we just kind of rub up against each other. Well, if there's semen with sperm in it, then that rubbing up against each other, and if the vagina is there, then the sperm starts swimming, then guess what? Risk of pregnancy. So moving on to the next one, the internal structures of the female anatomy are the fallopian tubes, as you can see, the ovaries. So that's where the eggs that we are born with and what they call ovulate, which means release, go into the tube, and then settles, depends on whether or not they get met by sperm, and settles inside the uterus. And you can see right there, the uterus, and the lining of the uterus is called the endometrium. Then you have the cervix. So the vagina is a closed tube. You can see the vagina at the bottom. It's a closed tube, but the cervix is the opening to the uterus. So the cervix is where the sperm swim up through the cervix to the uterus, through the fallopian tubes, and meet the egg in the fallopian tube. It fertilizes it, and then it drops back into the uterus. Now, how does all of this work? Well, there is something called an HPO axis, and basically that is the brain to the pituitary organ inside the brain to the uterus, tubes, ovaries, and essentially that tells things when to go. And when those things are working in alignment, then you have the likelihood of releasing an egg, as well as if the sperm is there at the time that the egg is released, then they fertilize, and then they drop right back into that uterus, like I said, and that's how you get pregnant. So we've been talking about the sperm, and here we have the male anatomy. So you can see the penis and you see the testicles. So from the testicles, essentially you have a tube that goes from the testicles all the way down through the penis, and then that ejaculate, or let's go of semen. Within the semen is something called sperm, and the sperm has a head, has a midpiece, and a tail. And the sperm is manufactured in the testicles, And that's very similar to the ovaries. So the ovaries have an egg, it's manufactured there, and then it moves through the tubes. Same thing for men. But the difference between is women are born with the total number of their eggs that they're going to have for the rest of their life, and those eggs die off. Whereas men regenerate sperm every couple of days, and they essentially can do that for the rest of their lives. Now, important piece here is a part of contraception. So that's why I want to show you the anatomy. Remember, I said both men and women have a tube. Well, if you cut off the tube, then clamp the tube, then that can prevent the egg and sperm from meeting, which means you won't fertilize. More likely than not, there's still a risk of something called an ectopic pregnancy, which is a pregnancy outside of the uterus. So let's talk about the menstrual cycle versus menstruation. The menstrual cycle is a process that the female body goes through every 21 to 35 days. And we've had a discussion on our period or menstrual cycle. And the reason why it's called a cycle is because it's a circle. So every 21 to 35 days for most people, and some people can be more frequent than that, and other people can be less frequent than that, that you're going to have a bleed, let's say. And essentially what's happening during this cycle is you are releasing hormones, and you're going to hear a hormone called FSH. You're releasing another hormone called LH, which triggers your body to ovulate. And then you're also releasing hormones, estrogen, progesterone. Now, these hormones are important because depending on where you are in that cycle, those hormones are going to support or prevent a pregnancy from occurring. So, but menstruation is when you're actually shedding the lining of your uterus. Remember, in the last slide, we talk about what the endometrial lining is. And menstruation is actually shedding the lining of the uterus. And many people call that their period or their bleed. So moving on to the next, this slide just shows you kind of what a cycle looks like. So if you look at the top, the hormones, they're called the gonadotropic hormones. Those hormone levels at the top, there's two different phases. There's a follicular phase when remember I told you the egg that you're born with starts maturing, so it can release that egg into the body, right? So that's called the follicular phase. And in the follicular phase, you can see that the FSH level, which we track, and stays about a little bit elevated, and then there's a time when it peaks, and then it goes back down during the luteal phase. And that luteal phase is the time during that luteal phase is that time once the egg has been released and it's potentially getting fertilized. That is a time where everything is trying to create a fertilized egg and drop into the uterus so that you can get pregnant. You can also see something called the LH hormone, which the LH hormone is a hormone that stays pretty steady all month or all throughout your cycle. And then at one point you have an LH surge, and that LH surge causes ovulation. You can also go down to the third box and you can see what's happening with your estrogen and progesterone. So during the estrogen phase, your lining of your uterus is building up because it knows that at some point there's going to be an egg that's released that's called ovulation, and you want to have a nice bed or pad inside of your uterus. Now, if that egg gets fertilized, then the lining or the pad inside your uterus actually stays stable because the progesterone in your system, and you can see progesterone in the third box, look towards your right in the luteal phase, it's a blue line. That progesterone level goes up to stabilize that uterine lining. Now, if you don't get pregnant, both the estrogen and the progesterone, but the progesterone much more significantly drops off. And that is when you get your menses. So the the fourth box, you can see what's going on with your uterine cycle. And that actually means, okay, what is going on during that cycle time? I told you it's 21 to 35 days. What's going on in the inside of your uterus, and what does that lining look like? So, and the last level, which has your box there, you can see that when you have your menses, that is probably the time that you have your lowest amount of estrogen. And that is the time that you're sloughing off your uterine lining. And when it's time for that egg, right before it's time for that egg to release, the body's going to build up that uterine lining, and that's called the proliferative phase. And then during that time, the body's going to stabilize that lining, and that's called the secretory phase or secretory phase. And if you don't get pregnant, then you're going to slough off that lining again, and that's the cycle. So let me tell you, this chart, you have to read it over and over and over again. I started reading this chart when I was in high school because I was interested in biology. Through college, still didn't get it. Med school, I was like, okay, I got it for the test. But when I really got it was when I became an OBGYN resident. And even now, every time that I teach somebody else, I get it more and more, and it just sticks in my mind even better. So if this looks confusing to you, it's fine. It's okay. Alrighty, so when you are coming and asking us about, contraception or birth control, there's different things that we should always ask and do, even if you're doing something online. We should always know, okay, how old are you? What are what we call your G's and P's, which means how many times have you been pregnant and how many children have you had? How many miscarriages or abortions have you had? What happened with those pregnancies? Also, we want to know about prior contraception use. So what have you done to prevent pregnancy in the past? We want to know about your menstrual cycle. So we just talked about that. How often does it come? When does it come? How long does it last? How much bleeding do you have? Do you have any pain or anything associated with it? We also want to get a medical history. Do you have any past history of thyroid disease, diabetes, hypertension, any genetic disease? We want to know all about that because depending on what your medical history is, lets us know whether or not we're going to be able to prescribe you certain type of contraception options. And then, of course, we want to know medications because we want to know what could potentially be interfering with the function of your contraception, depending on which one you choose. We also want to know about previous abdominal, cervical, or pelvic surgeries, just because that lets us know, okay, what is your history in case a complication happens, or you have something going on that will preclude you or prevent you from having a certain type of contraception. We also want to know, are you a smoker? Do you drink alcohol? Do you smoke weed? Are you using any type of caffeine? The reason why is because some medications that we may prescribe to you, that may worsen the symptoms or the side effects associated with using any of those things. All right, and then we're going to want to know your weight and BMI. So why do we want to know this? Well, number one, we want to make sure that you are living your healthiest and wealthiest life, right? So we want to make sure that your weight is within normal limits for you or woman, your height, as well as some therapies that we prescribe are not most effective in people with a higher BMI or weight because they can have a higher failure rate. We also want to know about your thyroid gland because we want to know what your body is processing. And is there anything else going on that could prevent you from really understanding your menstrual cycle or throwing off your menstrual cycle that could cause us to miscalculate, which type of recommendations for contraception we use. As far as abdominal and pelvis, we want to examine you. We want to touch your belly. We want to do what's called a bimanual exam. And this bimanual exam means that I put 2 fingers inside your vagina. I feel for your cervix, your uterus and ovaries. We just had that anatomy lesson. And then also many times, depending on the last time that you've gotten your pap smear and HPV done, if I notice it's not done, I'm going to ask you to do your pap smear, HPV, and STD testing. Now, none of these should preclude you from being able to get your contraception, but I may be able to offer a different type depending on your history, as well as the risks. Of course, if you have an active STD, I don't want to give you a contraception that can increase your risk of having a abdominal or pelvic infection. The reason why I want to update your pap smear and HPV is not to prevent you from getting your birth control, but because I want to make sure that you don't have abnormal cells in your cervix that could lead to cancer. And of course, I don't want to give you birth control if you already are positive, so as far as pregnancy. So those are the reasons why. But none of these, except for a positive pregnancy test, should really preclude you from getting contraception. And even still, if that positive pregnancy test or if that positive pregnancy is within a certain time, then if your state or location has the opportunity for you to get an abortion because you have chosen not to continue with the pregnancy, then we need to know that as well. So all the different types of contraception. There are a lot. And what we have at the top is the more effective types of contraception, and then towards the bottom are the less effective contraception. Number one thing I want to tell you, only usage of a condom, whether male or female, is helpful in reducing or preventing sexually transmitted diseases. So if you are not in a monogamous relationship, and monogamous for long term, I really want you to hear this, monogamous for long term, because some people think long term is 6 months, some people think it's a year. But the whole point is, if you are having sex with someone else or your partner is having sex with someone else, then there is a risk of having STD transmittal. So I want you to be very aware of that. So we're going to start with the less effective forms of contraception, and the reason why they're not as effective is because of just their failure rates associated with that. So you can see here that you have the diaphragm or the sponge, and these aren't as utilized in the United States as they once have been. And the reason why is because the failure risk is so high. The other thing that you can do is fertility awareness, and that is essentially tracking your period. So this is why it's really important to utilize an app, utilize your calendar to track your periods. Remember, we said that you have a menstrual cycle, and there's a certain time in your menstrual cycle that you're more likely than not to get pregnant. Well, we don't want to have sex during the time that we most likely are going to get pregnant, because we want to prevent pregnancy. So that's a very important piece to this. The male condom. So the male condom is very, very, very commonly used. And if used correctly, then the failure rate is, less than 3% really. So, but we want to also use a condom if there is less, if you're concerned about STDs. Okay. Now, when we can go to our other medications. So we have the injectables. So you've heard of that. It's Depo-Provera. It's given every 3 months, and you need to come into the clinic or a pharmacist to get your shot every 3 months, and you just need a negative pregnancy test. There are side effects that are associated with that. A lot of people talk about weight gain, hair loss, and acne. Those are the 3 big things that I hear people talk about. Then we have the birth control pill. So the birth control pills, there's several different formulations. Typically, they are combination pills, and those combination pills are combined with estrogen and progesterone. You typically take them 1 pill every single day. There's usually a placebo week, which means it's a sugar pill week, or if you don't want to have your period, you leave out that placebo week and you just take the active estrogen progesterone combination pills every single day and don't take the sugar pill. You also have the patch, and the patch brand name has been called Ortho patch. And essentially what you do with the patch is that you change them at various amounts of time. So the patch you change out once a week. The ring you change out every 21 days or 3 weeks. The nice thing with the pill, the patch, the ring is you can use them continuously and change them out on their set dates. But you don't have to do a placebo week if you do not want to do that. And that will allow you to have, go for time periods that have where you will have no actual bleed. And sometimes you can have like breakthrough bleeding associated with that. So you have to be aware of that. Of course, there's always risk factors and side effects associated with every single medication that we take. So there's always a risk of pregnancy. There's always a risk of having vaginal discharge, increased or decreased, as well as vaginal infections. So you hear people talk about, I have bacterial vaginosis or yeast infections. So those are things that can happen as well. And then lastly, our tier 1. So this is our implants, our vasectomy, tubal ligation, and our IUDs. And remember earlier, I talked about both men and women have a tube. And this tube is a conduit or a way for the sperm or the egg to move along the anatomy system, depending on if you're a man or woman. Or when we cut those tubes or if we clamp those tubes, then that will prevent or lower the risk significantly of pregnancy. Very, very important thing for men who get a vasectomy, that you get a post-vasectomy semen analysis. This is very important because we want to make sure that you are not expelling sperm, okay? If you still have sperm in your semen, then you can get somebody pregnant. So there is something called a post-vasectomy semen analysis, really important. In regards to a tubal ligation, unfortunately, women, there's no way for us to tell whether or not your egg or sperm can sneak through there. I personally, when I do tubal ligations, I actually remove tubes and I inform my patients that the likelihood of you getting pregnant is almost zero. The reason why is because if you come to me and you tell me that you absolutely do not want to get pregnant, after I've counseled you that if you're at, less than 30, the likelihood of you just changing your mind after 30 years of age is about 60%. But you say that you do not want your tubes in place and you do not want to get pregnant and you understand what it takes to get pregnant as far as fertility treatments, then let's go ahead and remove those tubes. That also decreases your risk of fallopian tube cancer. And then here you see the implant. So the implant has gone through many different names over the years. So I remember when it was Norplant and there was 5 different implants that go in your arm. Then there was the Implanon, and now we have the Nexplanon. So essentially what the implant is a progesterone only device that goes into your arm, and you can leave it in place for a number of years. And depending on what you're using it for states how many years that you can leave it in place. And so during your consultation, we would talk about, how long do you think that you would like to leave this in place? The other is called the IUD. And just to let you know, the tier 1 or the top level, all of these need to be done by a board certified OBGYN or a women's health nurse practitioner, family medicine physician, somebody that has had specific training in implanting devices in women's uteruses or specific surgical training of removing tubes or clamping off tubes. So the last one is the IUD, and this is the one you're going to hear the most about these days. The reason why is because along with the implant, it is called a long-acting reversible contraception. So long-acting reversible contraception because the IUDs have 3 different amounts of progesterone hormone in them. They go inside your uterus. We started with that female anatomy. We place them when you are not pregnant. Although it has been found that the IUD, if somebody is interested in not keeping a pregnancy, depending on how many weeks along they are, you can place the IUD to utilize it as an abortive fashion. But once it is in place, it does not typically abort a pregnancy. So the IUD is placed, and it's placed when you come into the office. We do a pregnancy test. We make sure all of your exam is up to date and that we can fit your IUD into your uterus appropriately. And we clean off your cervix, we measure your uterus, and then we place the IUD. I like to place the IUDs typically right at the end of your period. The reason why is with a negative pregnancy test and you telling me you haven't had unprotected sex, then the likelihood of you getting pregnant or being pregnant when I place it is very, very, very low. Also, at the time of IUD placement, you can do an STD check, and if that comes back positive, you can treat the person appropriately. But if somebody has significant vaginal discharge or what appears to be an infection, it is not recommended to place an IUD at that time. You can also get IUDs placed immediately postpartum. So as soon as you deliver a baby, whether by vagina or C-section, you can have an IUD placed as well. Now, the IUDs can last anywhere from 3 to 12 years, 3 to 10 years, depending on which one you're using. And there's literature out there that says you can actually use it up to a year or 2 longer than the actual package insert says. But that's something you definitely want to talk about with your provider. And as you know, contraception, the long-acting contraception, as well as the pills, the patch, the ring, the injectable are reversible. So whenever you choose to stop utilizing these forms of contraception, then you have the opportunity to get pregnant. And sometimes that pregnancy will happen within a month, and sometimes it will happen within a couple of months. But if you have stopped your contraception and you have not been able to get pregnant, depending on your age, between 6 and 12 months after stopping it, then that would be a reason for you to undergo a fertility evaluation if you want to get pregnant. And as I said, there are benefits, of course, of contraception, and there are risks. Also, remember that many people use these forms of hormonal control to help with excessive bleeding, as well as mood swings. And those are the main things, or perimenopausal symptoms, or PMS symptoms. So all of these formulations can be utilized for more than one thing. A couple of the big risk factors associated with utilizing a hormone-based contraception, especially estrogen hormone-based contraception, is the risk of elevation of blood pressure when we get older, as well as the risk of blood clots in your legs or your lungs. So it's really important to have that conversation about not only your past medical history, but your family's past medical history, especially if anybody's ever had any signs or symptoms of a blood clot in their legs and their lungs. The third thing is that we want to think about is migraines. So if you have a history of severe headaches with aura and you've been diagnosed with migraines, we need to be very careful about which contraception that we offer you. There are options for you, but we just need to be careful about that. Let's talk about emergency contraception. So emergency contraception, you've heard about Plan B. You heard that more likely than not. But really, emergency contraception is a high dose of progesterone or an IUD placed within 72 hours to 5 days of you having unprotected intercourse. So nowadays, many places you can have a pharmacist that prescribes that morning after pill for you, called Plan B or Ella as well. The IUD, like I said, needs to be placed by a women's health nurse practitioner, a family medicine physician, or an OBGYN, or somebody that has been trained specifically in placing IUDs. All right, and these are our resources, and my thanks to the community members that have helped us with this. We thank you very much for helping us with this information. And that is all I have for you today. So I'm going to. All right. Thank you for being a part of the Viva Life experience. I'm Dr. Kelly MD, board certified OBGYN and healthcare executive. If you like what you heard, then please go ahead and like, share, and subscribe. The reason why is because we are trying to educate, encourage, and inspire 1 million people to live their healthiest and wealthiest life. And this is what we're bringing you. We're bringing you educational videos. We're bringing you podcasts. We are bringing you webinars with subject matter experts, including myself, about the topics that affect you the most. So go ahead, like, subscribe, and share. We are everywhere. Have a wonderful day. Viva Life.